So welcome to all of you for this webinar that is part of the series of ReCONNET webinars. The topic of today is pretty topic for patients, because we'll treat a very, very important aspect that may be part of the success of the therapy that are assigned to the patients. And so it's related to how to improve the adherence to treatment. It's very easy words, but important and fundamental words. We will have three speakers interacting between them. And Coralie Bouillot, IPAG for Sjögren Europe, Ilaria Galletti, IPAG, Vice Chair of FESCA and GILS, and Rosaria Talarico, coming from the Rheumatology Unit, the University of Pisa. They will interact with important questions and possible answer. At the end, you should really, I think, catch some important advices on how to adhere at the best to the treatment. I would like to invite, I think, Sarah, maybe the first speaker. And please, Sarah, start your presentation. Thank you.
Yes, thank you, Professor Cutolo, for the introduction. Just a few words. We will try to organize this presentation in a sort of dialogue. So I pass the floor to Ilaria for the first question.
Yes, and it will be for you, Sarah. Thank you, Prof. Cutolo, for the introduction. And thank you for everyone attending this topic. And I want to ask Sarah, why is it important to talk about adherence? Why are we here today? And what is important for clinicians and for patients? Because this is a crucial topic, in my opinion, in our opinion.
Thank you, Ilaria, for the question. It is really the starting question of this webinar. We are here today talking about adherence to treatment, since adherence to treatment is really a very big issue for patients, for clinicians, for all the stakeholders involved in the process of taking care. And it is so complex that when we try to describe and summarize this issue, I'd like to talk about an issue, not really a problem, summarizing it with this picture. Since adherence to treatment is really an elephant in the room, since everyone knows about, but no one wants to discuss, no one wants to mention this issue. And probably it's due to the fact that it is really uncomfortable to talk about adherence to treatment, or low adherence or no adherence to treatment. It is uncomfortable for patients, for caregivers in many cases, but also for clinicians, since we are taking care of the process, but we know that adherence to treatment is something related to personal issue, to clinician issue, but it is also a public health issue. So we are here talking about adherence since we would like to break the barriers on talking about adherence to treatment and try to suggest some practical suggestion on considerations that may improve the approach of patients, caregivers, and clinicians to adherence to treatment. But how can we define adherence to therapy in general, not only to drugs? Adherence to therapy describes how a patient follow a prescription in terms of drugs, medication, but also in terms of diets or lifestyle changes, many things that a clinician or other healthcare professional may recommend to patients. Unfortunately, a poor medication adherence may associate with a poor health outcome in terms of quality of life, but also in terms of economics aspects of the healthcare systems, and obviously on the impact of the outcome of the disease. But how much is the weight of the problem of adherence? According to WHO, adherence to treatment has a impact on the disease, on patients' outcome, higher than the treatment itself. I know that it is a very strong statement, but it really represents how adherence to treatment is important in the process of taking care. And the problem is not only for acute disease, but also, unfortunately, for chronic disease. We are here talking about rare and complex connective tissue disease, but all this discussion is applicable also for all the whole field of chronic disease. And very surprisingly, the adherence to treatment in chronic disease is low. There are a lot of data indicating that in many cases, adherence to non-adherence or low adherence is around 1/3 of patients, but there are a lot of data indicating that probably half of the patients taking drug are non-adherent to treatment. So it is really surprising, but is really, really important in terms of outcomes. And in this regard, I pass the floor or Coralie, which a very important question. Why adherence to therapy, to treatment and to therapy in general is so important for patients? Please, Coralie.
Thank you, Sarah. Sarah, I must admit that the figures you've shown us are particularly worrying. Of course, the first answer to this question seems obvious: to make the patient feel better for his well-being and its health. But we must go beyond that quite obvious answer. Treatment, as you said, does not only consist of drug or medication. It is often complemented by physical therapy, lifestyle advice, and psychological support, especially in our rare and low prevalence disease. So it is really important for patients to understand why they are being prescribed physio or psychological consultation. A very common example for this is weight loss. Almost all patients do not understand why the doctor is asking them to watch their diet. But once the patient understands, for example, that weight loss can, in some case, alleviate joint pain, adherence will be better for sure. This explanation, whether it is a question of lifestyle, psychological follow-up, or taking medication, are really essential for several reasons. To understand the prescription, of course, and the importance of the recommendation, but also, and above all, to understand the disease. I think, and I'm not the only one thinking, that understanding the disease, the different symptoms, and the damage done will allow us, patients, to make sense of the overall therapy. Again, an example: why am I being asked to do sports when my joints are already in so much pain? Once we understand why it is essential to maintain physical activity in musculoskeletal disease, adherence is better once again. So it is no longer a question of doctor injunction that is not very well received by patients who feel that they are being judged, but rather an active participation in the management of their disease and partnership. So understanding its illness also means establishing a dialogue with the clinician, whether it is about the mechanism of the pathology, its potential complications or damage, or the use of medication. Asking questions or having a dialogue with the clinician, with the doctor, will allow the patient to be better informed and more educated. So a frequently example is the case of medication to be, for example, taken at certain times of the day. If the patient doesn't understand why, the treatment may be stopped or not effective. So active participation of the disease and better understanding will also allow patients to better explain to his relatives and his environment at work or friends or family members, and to explain the ins and the outs of the therapy. The side effects, for example, fatigue and physical therapy session, can be better understood and accepted. The dialogue and communications also fight against preconceived ideas, fears, and misunderstandings. Indeed, many patients stop or do not start, it happens, their treatments because the lack of information or fear. But they don't tell the doctor, who then thinks that the treatment is not effective, or thinks that the dose is not appropriate. This can obviously put the patient's health at risk. Increasing the dose, by example, of corticosteroids or anti-inflammatory drugs is not without risk, but it will be the doctor's suggestion if the patient does not improve. So this situation are seen every day, and patients are talking to patients about it, but not to clinicians. We also hear from patients that they don't dare to ask questions, or they say that clinicians don't have time. We all know that this is a reality, but patients, the specialists are not the only one who can explain therapy. Nurses, GPs, pharmacists, physiotherapists, any health professional can answer questions and give explanation. So again, the patient we must be actor of our therapy and not remain isolated with fears, preconceived ideas, or unanswered questions. So we'll see later, I guess, what possibilities are offered to patients to be at the heart of their care with a single objective, better health. So again, we have listed about patient, about the feeling of patient, but Sarah, you as a clinician, what is your opinion and what is important for you?
Okay, thank you, Coralie, and thank you for your suggestions, practical suggestions, also in consideration for patients. Why it is really important also for clinicians, since it is an issue also for clinicians, since clinicians should take care of patients living with the disease. So it is really important to take care of how and how many therapy the patients can take in the long term. But we are talking about connective tissue disease, rare and complex. Again, these principles are applying to many other chronic disease. And as you can see, a part of the adherence to treatment, we have a lot of problems, I can say, regarding the management of this disease, since we experience patients and clinicians late in diagnosis in many cases for the complex disease, for rare aspects of the complex disease, and in many, many cases for the rarest diseases. Our disease, our systemic autoimmune disease in general, are characterized by relapsing remitting course, and it is very tricky for the management of the disease in general, also considering the therapy and the adherence to treatment. We have different phenotype of expression, and it is really difficult in managed therapy. There are a lot of rare condition, complex condition, and we have a lot of off-label drugs that we use in connective tissue disease. So we start with a lot of problem before talking about adherence to treatment. But we have a very big problem regarding adherence to treatment in chronic disease and in systemic autoimmune disease specifically, since if we do not know if a patient takes a drug or not, the effect of non-adherence to treatment or no response to treatment is the same result, no change in the disease course. So it is really important when deciding from the clinician point of view, but it is all in terms of a decision-making process. So something that involves clinicians, but also patients and caregivers. If we do not know that there is a low or a poor adherence, we may made a mistake and misunderstand what is a no response to therapy, that it is a no adherence to treatment. So it is really important for the clinician to talk about a treatment to be adherent or low adherent. Since we may manage the treatment, we may discuss together with the patient and the caregiver, and the main objective, the main endpoint is to treat the disease, the relapsing remitting course. So it is important if someone is not taking a drug. we have to consider, as Coralie has mentioned before, that adherence to treatment is a really multidimensional phenomenon. And we should start from the physician-patient relationship. It is really important, since adherence to treatment means also communication, a good communication. And it is mandatory, since we are talking about drugs. Obviously, we are not the same, we are different also in the disease. So patient's characteristics may influence how a patient may be more or less adherent to a treatment. But we have to identify this profile, and an evaluation in the outpatient clinic should include the consideration of the patient's characteristic in terms of adherence to treatment. Since we, as clinicians' point of view, we observe not a patient, we observe a person living with the disease. So the disease is in the framework of life, work, family, and many other things. So we should always consider all the dimensions that we have to take care in the adherence to treatment. Other dimension that may have a role and play a role is represented by the administration routes. But there are some data indicating that route of administration of a drug, oral or subcutaneous, is not important in the level of adherence to treatment. So again, probably there is a matter of communication, of explanation. And explanation means also information regarding the disease. It is really important to talk about how the drug should be taken in the follow-up, the efficacy and the objective. We should discuss together with you, patients, what we are expecting for. We are prescribing a drug in order to observe a specific effect and not another. And in many cases, if we do not know why we are taking these drugs, probably we cannot observe the effect of the drug, and obviously not to report the real effect to the clinician. So again, communication is really important, but information on what we have to observe in the follow-up is really, really important. And all these things can be included in what we call patients' empowerment. That is a big dimension that includes all these things that you can see in the slides, but all the process, all the decision-making process in which the actors are patients, caregiver, and clinicians. And communication is the cross-sectional way to improve this. So discuss, don't be ashamed of talking about no adherence or low adherence, since it is a matter of your disease, your therapy, and the outcome of your disease. So again, please, let's break the barriers on talking about this problem. And now I give the floor to Ilaria regarding some practical examples from the patient's point of view of low or non-adherence in real life. Please, Ilaria.
Thank you, Sarah. Yes, as you can see, one non-adherence practice regards the antibiotics. Usually the prescription says 6-10 days, but already after 2-3 days of therapy, the person feels better and thinks that that's it, stops taking the pills. But what happens is that the bacteria or the fungi in the body keep on duplicating. So this leads to make another therapy, and this leads again to a resistance. Probably, if it happens, the next pandemic or catastrophic event will be the antimicrobial resistance. Every day people die because they can't fight the bacteria, because the antibiotics do not have effect against that bacteria. So please, if you receive a prescription that states 6 days, please take 6 days therapy. Another aspect that has been already mentioned is the remission. So it's more or less the same. When we feel better thanks to the therapy, we think, okay, I don't need the medicines or the therapy anymore. And this is not correct, because we have to think that the positive outcome is given by the therapy. Another example can be the prevention. Some therapies are not used to cure, but to prevent effects. There is a study that shows that how many people, a high percentages of people that had a stroke and need to take pills for the cardiovascular system are not adherent, even after a stroke. And we have also to distinguish the voluntary non-adherence and the non-voluntary non-adherence. I mean, maybe I forget to take the pills, or as in the example that I brought before, I decide not to take the pills anymore. Or fourth example, it's my personal experience. One of my therapy is to train my body. I am one of the laziest person on the world. So sometimes I say, oh, I look at the monster machine and say, come on, tomorrow, I will do it tomorrow. But that's part of the daily therapy. And I am conscious that I'm making a mistake. And I'm doing it, but I'm trying to be better and better. So, sorry, that's are the main examples that I have in mind.
Thank you, Ilaria. And regarding what you introduced in this, how you can interpret the barrier, or which are the potential barriers for low non-adherence to therapy from your and patient's point of view?
There are many, about 5 big areas. One is the condition related. If we think, for example, of diabetic patients, they must be very compliant, adherent, because it's different, compliant and adherence. Adherence means an active role of the patient more than compliance. Well, diabetic patients must be adherent, otherwise they suffer extreme consequences. But even among diabetic patients, some are not adherent. Another example could be people living with Alzheimer's disease. They can't remember the therapy they have to follow. They need to rely on someone else. Or depression. Again, depression can lead to be not adherence. Or a subcondition of the disease that has an opposite result is pain. When we have pain, we are usually very, very adherent. And we should remind that pain is a consequence often of other problems. And instead of waiting for pain, be active in advance. The second point is related to the patient. As has been said and will be stressed after, the lack of involvement in therapy decision-making is one of the reasons why patients are not adherent. If we have a discussion with our clinician, if the clinician maybe asks, when is better for you to take this pill, in the morning or in the evening, because of habits, maybe if it's just a one dose of medicine, this could help the adherence treatment. There is often no literacy among patients about the disease, what happens without following the therapies. And also, let me stress the poor understanding of the medication. Nowadays, we have a multicultural society. we have many foreign people living in our countries that don't speak our language. The medicine leaflet is only in one language. So we have to consider that many patients don't understand what's written. And this can lead to a non-adherence behavior. And the third part is related to the therapy. We have talked about side effects. Okay, we know that every medicine has a side effects, at least potentially. So I guess that during the consultation, the doctor or the GP should explain, you can have these effects. I suggest you to take this other medication or to change your behavior, change your diet in order to overcome the side effects. So information and help provided to patient. As we said, sometimes we have to depend on other people, like injection. If I have to make an injection, I have to ask someone else to help me. And this could be also another reason for low adherence. And then the fourth point is socio-economic. Many therapies have high costs. They are not reimbursed by the healthcare system. I'm thinking about psychologists, physiotherapists, but also some medicines over the counter as well, without any prescription. And many patients even don't have the possibility to travel and to move to reach the specialists they need. The fifth issue is really crucial, because if patients are not within a well-organized patient care pathway, they are keen not to be adherent. And this is not my thought. I have the evidence of that. So has been tested. We in ReCONNET have developed the ERN path that takes the patient by hand and let him or her have multidisciplinary consultations, and so different prescriptions, but all the stakeholders involved in the patient pathway can talk to each other. Why are you prescribing this pill? Why are you not testing the other one? And it's a very recent data from yesterday, Italy. Clinicians have a maximum 9 minutes for consultation, 9 minutes. So how can I expect clinicians to give me information about how the medicine works? Why do I have to follow the therapy for so much time? This is because of costs, but it's not cost effective, this way of working, both for clinicians, for patients, and for the healthcare system itself, because when we said that some drugs, some therapies are prescribed because of a prevention issue, if we don't prevent a worsening or the episode of the disease, the healthcare system has to invest much money in the future. And for this thing, I think that we don't have enough non-medical personnel. I mean, nurses could play an important role, because there is often a better dialogue between patient and nurses rather than between clinical and patients. Coralie said before, dare to ask. Maybe it could be easier to ask, in my experience, that to ask a nurse or to receive some information, counseling from a nurse rather than a clinician. But anyway, the information is crucial, the literacy is crucial, and the awareness on this topic is crucial as well. Thank you for the question, Sarah.
Thank you.
And now, after having raised the problems, Coralie, please give us some ideas for possible solution, how to overcome all these 5 pillars.
Yeah, ideas, advice, tips. It will be things that we have already said. You, Ilaria, or you, Sarah, as a clinician. Patient empowerment. I think if you look carefully to the slide, it will be written patients and not a single word for clinicians. Sorry for doctors. But the meaning of this one is that the patient is at the heart of the treatment, of the therapy. The patient is at the center of their disease management. And I hope now you understand that communication is the key. And above all, the key to make the patient feel better, to manage its disease as well as possible. So let's be clear. We often listen to patients and we can hear some saying, I'm sorry, and feeling guilty. So again, let's be clear. No one asked to be sick. There is no guilt to have. Even though we know perfectly well that it is how most patients feel, especially women, but no guilt to have. That's the first thing to think about it. The second one is that there is no silly question. It's a shame to think that your question is stupid and that the doctor will, I don't know, laugh at you. If you don't dare, if you don't have the time, turn yourself, go to see and take an appointment with other healthcare professionals. You can talk to, as Ilaria said, to GPs, pharmacists, nurses. Maybe sometimes in hospital you will have some students which might have more time than a clinician. So again, no question is stupid, and please ask. And if you don't have the possibility, turn to reliable and reputable sources of information. That's really, really important. Reliable sources of information are patient organization and scientific society. As you can see, patients can find many answers to their questions on internet, but please, please, my fellow patients, not just anywhere and not with anyone. I'll give you a very common example of the harm that a patient forum on social media can do. Hydroxychloroquine, which is a plaquenil that most of people know now. Plaquenil is quite frequently given in pathologies like lupus or Sjögren, and it is frequently stopped by patients on their own for 2 main reasons. The first one is the lack of information about the drug. It doesn't do anything for me, so I stop it. As Sarah said earlier, we need to have some explanation because patients think that hydroxychloroquine is given as painkiller. So this may be the case sometimes, but it is not why the doctor prescribed the plaquenil. The second example, the second reason is an excessive fear of side effects. We often read from patients that patients are afraid of going blind. So we all know that there are risks of retinal damage, but these are known, reversible, and again, very well documented and known by doctor and monitored. So again, if you don't want to take that pill, that plaquenil, because of that risk of retinal damage, talk to your doctor. So Patient must ask questions and not be left without answers or with dangerous answers. Misinformation is a real danger for the patient self. Another very recent example is the COVID vaccination. Patients read everything everywhere, and many were lost and distressed. We, as patient association, did have a lot of phone calls, and some patients were crying on the phone because they didn't know what to do. So again, be careful with internet and social media. In the first case, you have to contact your doctor, but more widely, the Federation of Associations that issues scientifically validated recommendation. That's very, very important. And as we've seen, the dialogue with the clinician is essential to dispel certain doubts and fears. Sharing decision and adapting treatment, as Ilaria said about the pills, is essential to ensure its sustainability and to prevent for quitting the treatment or non-adherence. By example, if you are afraid to take your medication at work because you don't want the others to see how many pills you take, there might be a solution to allow you to take them differently. And if not, the patient might need to be accompanied by a psychologist, maybe to help just to talk and go over that social feeling. Again, Ilaria gave some examples, but I don't know, if you are really afraid of needles, just say it simply to your doctor. There's no shame, and the doctor might find another an alternative method of administration. And still, if you can't afford some treatments, by example, over-the-counter drugs, or maybe treatments which are not reimbursed, just say it simply. There's no shame for that as well. So this is called, again, as Hilary said, and that's the first arrow on the slide, sharing the treatment decision. If a treatment is understood, adapted to the patient's lifestyle, or simply to his will, it will be followed more. No situation is embarrassing, and in the vast majority of cases, a solution can be found. In order to find solution, we must understand the barriers, and please keep in mind, again, fellow patient, that the doctor is not a mind reader. The patient must explain. We must explain. So speaking of explanation, don't hesitate to ask a relative, a family member, your partner, to come with you for your medical appointment. This will allow this person to hear the recommendation and better understand your illness again. And this is especially true for invisible illness, where patients often say, no one understands my fatigue or pain. So that will also facilitate the dialogue with your family members or friends or whoever you are close. And that will also offer the opportunity to have a true discussion about the management of the disease and the therapy. That can be something to explain why you can't do such things, or why you need some rest, or why you need to eat at regular time to take your pills. Again, it's a question of communication. So in summary, my take-home message would be there to talk to talk about your difficulties, about your fears, there to ask your questions, there to tell your doctor that the side effects are no longer tolerable for you. Many patients hide their difficulties for fear of being judged, as we said. This could be the case. Yes, it happens, but never mind, because that's your health, that's your future. So that's why it's so important for you to take that and keep that in mind. So many are here to help you. Contact the patient association for your disease, if there's one. And if not, a rare disease patient association. In addition to reliable information, you will be able to exchange with other patients who are trained and able to answer your question. So in conclusion, I'm convinced that a better communication between patient and clinician can have a real positive impact on adherence to treatment. But again, that's the patient view, and as Ilaria, I might sometimes miss some exercise or some pills of everything. But again, being well educated will enable you to maybe to listen to you better, to adapt your treatment, to find what works for you, and to detect signs of exacerbation. But again, this is our view. Sarah, what do you feel about that relationship? And sorry for saying that sometimes we don't have answer to our question, or sometimes you don't have the time to, but I think it's a reality. And we often listen to our patients, and it's a reality for them. Yeah.
Thank you, Coralie. I want to link to your work, since communication and education are really, really important. And as clinicians, we should find the time to ask the question to the patients. It's part of our work. It's not added time. So it is really important, and it means added value for the relationship between clinicians and patients. And if we want to summarize some key points, practical points for try to improve adherence to treatment, I would like to show these slides that we already used actually for the webinar for clinicians, but it's the same thing. We need to do the same thing. We need to discuss about the disease and about the adherence to the treatment that we as clinicians prescribe to a patient living with the disease. It is really important to discuss, please. Remember these words. Let's not that these slides are only slides as words. It's practical life. Discuss is really, really important. And in order to discuss and explain the disease, it's important to explain how to monitor and how to monitor the treatment adherence during the follow-up. Otherwise, at the next evaluation at the outpatient clinic, we cannot describe and observe the disease itself, but only partial information. And it is not correct from the taking care process. It's really, really important to explain how to monitor. You already say both. It is really important to have a trust relationship. It is for the relationship between teacher and kids, but is more important for a relationship between patient and doctor. But the example of teacher and kid is the same, only in terms of education, information, and explanation. It is our duty as clinicians to explain to you what you have to take as drug, which is your disease, which are the aspects of your disease, and the tricky aspects also of the treatment. And it means educate on the disease. Education also of the caregiver, as you already said. It is really important, since caregiver, family member, and partner are actors of the disease, since you have a disease in your life, so in your world. And the last thing for me personally, the most important, is to check that the information that we provide as clinicians are really catched from patients and from caregiver. Otherwise, the information regarding the disease, the information regarding the treatment are not usable if I'm not checking if you really understood the concept of the adherence to treatment and of the disease. These key points are really important for both, for patients and for clinicians from different point of view. But again, we are talking about adherence to treatment, since we are talking about a good communication, a good relationship, and a good information, education about the disease. So thank you for this question.
Thank you very much to all of you for this very, very, very well-focused discussion and presentation of topics that are reality for all patients. I'm sure that patients that will follow this webinar, we recognize a lot of problems and barriers they have every day. I would just to add 2 or 3 comments, if I'm allowed. It's correct, the 5 points that Ilaria showed from the WHO, and the 5 points as a conclusion presented from Ilaria. There is only 2 or 3 comments that I would say, because there are different diseases. For each disease, there is a different approach. There are short-term disease, long-term disease, but there is also, during a disease, the interaction between doctors, because you may arise a new problem, as surgery, maybe another psychiatric problem. So the patient is under consultation from different doctors and probably different drugs. And here starts sometimes the problem, the interaction between drugs, the interaction between different suggestions and different advices. So this is a problem that probably should be, has already discussed and summarized, by a clear and frequent consultation from each one of the doctors. So if some side effects arise or no effects of the therapy or even worsening, it's better to get the possibility to interact with the doctor, prescribe to you the new drug, the new treatment, or even sometimes ask to you to stop the treatment, the previous treatment, and start another one. Because sometimes here is the problem for the patient, is totally embarrassed what to do. And sometimes here arise also the insufficiency and non-adherence induced by the confusion that is induced by different advice. So I think that at the end of this webinar, in any case, the final advice, the final suggestion that all of you formulated is that between the doctor and the patient must be clear, a very efficient cooperation, consultation, and advice without any barrier between humans. Because if there is a barrier between humans, of course, the final result is non-adherence and non-trusting the therapy administered. So I hope all of you are happy, and of course the panelists and also the people that are present during this wonderful webinar and will learn in the future of this webinar. Thank you to all of you, and see you soon with another webinar.
Thank you.
Thank you.
Thank you, Coralie and Ilaria.
Thank you. Thank you. Bye-bye. Thank you.
Bye.